Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Disability Competency Training in Medical Education, and it was presented by Danbi Lee along with guest moderator Tracy Mroz on September 28th, 2021.
My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. Today's event is the seventh in our series focused on health equity, and it's about disability competency training in medical education. Now, with that said, I'm going to go ahead and turn the event over to Tracy Mroz. Tracy is an assistant professor in the Division of Occupational Therapy at the Department of Rehabilitation Medicine at the University of Washington School of Medicine. Tracy is our guest moderator today. Tracy, would you like to introduce our presenter?
Thank you so much, David. It's my pleasure to introduce my colleague today, Dr. Danbi Lee. Dr. Lee is an assistant professor in the Department of Rehab Medicine and core faculty for the Disability Studies program at the University of Washington. Dr. Lee earned a PhD in Disability Studies and Doctor of Occupational Therapy from the University of Illinois at Chicago, and she completed a postdoctoral fellowship in health services and outcomes research at Northwestern University. She's a founding member of the Occupational Therapy and Disability Studies Network, which advocates for the integration of disability studies perspectives into the field of occupational therapy. She was also a co-investigator of the University of Washington Disability Equity Project, which aimed to co-create and implement a disability allyship training curriculum to contribute to an inclusive and diverse campus culture and facilitate discussions about disability as a key part of diversity, equity, and inclusion initiatives within health professions education. Dr. Lee has been an affiliate investigator with the University of Washington Center for Health Workforce Studies since 2019. Today, she'll be sharing a recent study she led investigating the current state of disability-related trainings in medical education programs. Over to you, Danbi.
Thank you so much for the introduction, Tracy. I'm going to give a brief overview about a study that we have completed to understand disability competency training in medical education. I wanted to first acknowledge the University of Washington Center for Health Workforce Studies, particularly the Health Workforce Research Center for Health Equity, funded by HRSA, and our research team, which includes Samantha Pollock, Tracy Mroz, Bianca Frogner, and Susan Skillman. So people with disabilities are an unrecognized health disparity population who continue to experience multiple barriers to adequate health care. These barriers include inaccessible environments, inflexible policies and procedures, and social assumptions. But one of the barriers that has been largely recognized is the lack of training among healthcare providers that addresses negative attitudes towards disability and the wide range of healthcare needs of people with disabilities. Disability competency has not been a priority because it's not required for medical school accreditation or licensure in the US. Recognizing this gap in health and medical education, the Alliance for Disability for Healthcare Education developed and published core competencies on disability for healthcare education in collaboration with experts in medical education and the disability community. I wanted to quickly go over the 6 core competencies as they guided the study. These include understanding different conceptual frameworks of disability, demonstrating professionalism and acknowledging patients' perspective, understanding legal requirements for providing healthcare consistent with federal laws, engaging and collaborating with team members to provide high-quality healthcare, and then being knowledgeable about clinical assessments and clinical care to patients with disabilities. With these core competencies available, the purpose of the study was to gain insights into the extent to which medical education is addressing these competencies, as well as how these competencies are addressed. We also wanted to understand facilitators and barriers to integrating disability competency training to identify potential strategies for more integration. We used a mixed method design where we started with an online survey that was followed by qualitative interviews. The survey included 23 questions with multiple choice questions on disability core competencies addressed in curriculum. There were open-ended questions about specific learning activities that would address the core competencies. And there were also questions on facilitators and barriers, as I mentioned. The survey was distributed to all allopathic and osteopathic medical schools in the US between February and June of 2020, which you may have noticed that the data collection period overlaps with the first few months of the COVID-19 pandemic, which influenced our response rate actually. As a follow-up to the online survey, we conducted 30-minute individual qualitative interviews to gain insight on what we have learned from the survey data, and we recruited faculty members through convenience and purposeful sampling. We used descriptive statistics for quantitative data and thematic analysis to analyze the qualitative data, and the data were then integrated, as you will see in the results section. We had 14 survey respondents. Majority were from public allopathic medical schools in the South with 100 and more students. And this was similar among the interview participants too. So going into the findings, when we asked respondents to tell us which core competencies are met in their curriculum, they reported that many of the core competencies were addressed, as you can see in this top table. Majority of schools also reported that they're addressing 5 to 6 core competencies out of the 6. However, when we look closely at the learning activities they reported, most schools only offered single sessions that lasted about 45 to 90 minutes, with a few that had more than one session. Activities included lectures, cases, stories from people with disabilities. There were patient encounters, with a few that also had community engagement as part of the training. Most learning activities were required and completed during the first 2 years of medical education. And this was also confirmed in the interview, where the participants noted that skills and understandings of disabilities were rather seen as foundational, but then they were not integrated in advanced training. And you can see a quote from a participant here. Content-wise, majority reported addressing topics such as challenging ableism and implicit bias, learning about people's lived experience as a patient, and learning disability adequate in clinical setting and for physical exams. Some schools touched upon all of these topics and some addressed 1 or 2. Then there were also a few schools who reported teaching primarily medical content, such as diagnosing cerebral palsy or having rehabilitation rotation as ways to increase disability competency. These would be examples of medical model-oriented activities where disability is primarily seen as a deficit and individual problem, which is actually what the core competencies are trying to change. But we also found that not all of the other reported learning activities necessarily present disability within the diversity or social model either, where disability is seen as an identity and social construct. For example, students may feel confident interacting and communicating with patients through the standardized patient practice, but still see disability as a deficit if frameworks to understand disability or implicit biases are not talked about. So there was definitely a continuum on how disability was presented in these learning activities. In the qualitative interviews, participants acknowledged that the learning activities are often compelling, but not enough to shift students' understanding of disability. And one person, as you can see in this quote, particularly mentioned how disability is often seen as a negative health outcome and not part of human variation and as an identity. Regards to involvement of people with disabilities in competency training, majority responded that they invited people with disabilities as panelists or patients, and only a few had advisory members or faculty members with disabilities. As I said, we also asked about facilitators and barriers to integrating disability competency training. Most frequently identified facilitators, as you can see in this table, were having a faculty champion and support from academic leadership. And the biggest barrier was the lack of time in current curriculum to add new content. Consistent with the survey result, one strong theme across the interviews was the limited curriculum time to integrate more information, which would explain why most of the learning activities were single sessions. To deal with the curricular structure and time, some participants shared how it would help to spread disability content throughout the 4 years by embedding case studies or panelists as part of diversity, equity, and inclusion discussions. One person also said that obtaining external grant for developing learning activities helped them get their foot in the door when competing with other content areas. Although this would require someone to be an expert in this topic and this area, which actually leads to the next theme of the qualitative interviews. The data really bolstered the importance of having a champion who is willing to advocate for an inclusion of disability competency training. But this also brought up an important point that these trainings solely rely on those champions oftentimes, which means that if there's no champion, there's no training on disability competencies. And once the champion leaves or retires, the training gets lost. Participants also talked about the different institutional support and resources they utilized, such as having protected time or designated staff to coordinate the panel or patient sessions, funds to pay panelists or standardized patients and families, and the connection to disability organizations to recruit patient volunteers, as well as getting help on developing the curriculum. So moving into the discussion, limitations include, as you have seen, low response rate, and there's potential response bias in that schools with disability competency training were more likely to respond. The qualitative interviews were great in deepening our understanding on the topic, but the data did not reach saturation with 5 participants. So the study was more exploratory in nature. Despite these limitations, we learned that for most medical schools, there were not many opportunities for students to gain in-depth understanding of disability and the care that people with disabilities need. Most of the activities were done in the first 2 years without follow-ups. And given limited time in the curriculum, medical curricula could benefit from multiple opportunities over time for scaffolding that are integrated into cases and discussions around diversity and health equity. We also learned that faculty champions had critical roles in integrating disability competency training, given that not all medical schools have those champions and resources, and also given the challenges to integrate more content into existing curricula, we recognize the need to embed the core competencies into the accreditation standards. We believe those requirements would lead to more proactive integration, rather reactive, of disability content in medical schools, and ultimately improve then the quality of healthcare received by people with disabilities. Okay, so this was a quick overview of the study, and I hope I can address more of it in the Q&A session. Thank you.
Thank you so much, Danbi. We'll now go ahead and open up the discussion. As a reminder, please use the Q&A feature to ask your questions. And as you are starting to formulate your questions, I'll kick us off. So Danbi, over the past couple of years, diversity, equity, and inclusion initiatives have received a lot of increased attention. But why do you think disability is often not included as part of the DEI discussion?
Thank you for that question. Yeah, I mean, simply disability is often not seen as an identity. I think that's the biggest barrier to that. Disability is seen as a health condition, a negative outcome of incidents or accidents. often when people think about minority groups, disability is not seen as one of those because it's simply a medical condition to fix. And I briefly mentioned the medical model, but it's really putting the focus on the person versus the social structure and the system that creates the barriers that people experience. And not seeing disability as identity, it might be more common when you see someone who just had a stroke, who just had a spinal cord injury, and in those incidents, it's more a medical condition to treat at the moment. But over time, people develop this identity as a person with a disability. They learn how to work with the environment and how to advocate, and that becomes part of the identity, which needs to be appreciated and acknowledged by healthcare providers, but oftentimes we're still operating within the medical model where we see disability as something to be fixed and changed.
Thank you for that explanation. Still waiting for questions to come in for the audience, so please don't be shy. Well, you mentioned a little bit about the medical model versus the social model of disabilities. That's really helpful for those who may be less familiar with what those models look like. Could you maybe share some examples of how those two models might look in medical education and the differences?
Yeah, so as I said, the medical model really focuses on the individual. It sees disability as something to be fixed. So it's really trying to normalize someone's body and mind based on a medical model. And the only way to change that is medical treatment, surgeries, those kind of procedures. Versus in a social model, the focus is more on the environment and the system that surrounds a person. So it really looks at the intersection of the person's body and mind and the environment. And so, for example, a simple example would be where someone with a wheelchair would not be disabled if there were ramps or elevators everywhere without chairs, or if there were no curbs on the street. So based on that, I think within the medical education, I gave some examples of where the sole focus is on diagnoses or medical conditions, which is, I think, the traditional way of explaining or addressing disability in medical education. With the shift to the social model, would focus more on the ableism part, or the implicit bias we have, and really looking at the healthcare barriers that people with disabilities experience within the healthcare, which could be, physical environment, like having a weight that's accessible to wheelchair users. But also it could be a lot of times the attitude that people would experience, and part of it is seeing disability as a negative health outcome. So for someone who have lived with cerebral palsy for 10 years or, for 20 years or their whole life, when they come in for a broken bone, all of a sudden the disability is becoming the problem, not necessarily the broken bone. And that's more the notion that we focus so much on the disability, and seeing that as an identity would solve a lot of issues around that and the negative attitude that people with disabilities may experience.
Thank you. So you all are making my job as a moderator very easy. Please ask questions. I know that you must have some follow-up questions out there. Otherwise, I will continue drilling Danbi here with some of my own questions. I think one of the big challenges that you brought up was that there are so many time constraints within the medical school curricula, as well as a lack of accreditation standards specifically around disability. Given those factors, do you have any thoughts on prioritization of those core competencies, or how medical schools who want to do more but may not have the time, the champion, the resources to kind of go full force, where they might want to start?
Yeah, I mean, it's hard to prioritize because those, I mean, if you think about those 6 core competencies, they're all really important. But I feel like, having some foundational work in the first or second year would be good, just to help people frame disability in a different way and kind of shift their perspectives around disability. From then on, I think best, and this is also supported in literature, to use cases where the person is actually having a disability, which to bring in that perspective, and also have some additional questions maybe around how can you communicate best, or how would that change the care that you provide. Actually, there's an article was published recently where they actually provide specific examples of cases, how you can integrate the disability perspective into existing cases that would address other accreditation standards. Actually, I'm happy to include that when we post the slides later. But yeah, I mean, there including cases and more discussion, because diversity and health equity are a part of the accreditation. Disability is it's just not simply explicitly included in that standard, so it's often forgotten, right? But with yeah, I mean, if there's chances to integrate disability into existing discussion, I think that would be best ways to address those core competencies.
That seems like a way to both solve the time crisis as well as get away from the idea of this one session coverage to try to tackle the issues.
Right.
So we do have a question from the audience. Have you heard any of your patients say they focus on what they can do, not what they cannot? And what are your thoughts on this belief?
So I think you're talking more about the how to deal with those patients who say, I can do these and I can not do this. Kind of, they focus really on their ability versus other things. Yeah, and and this is thanks for this question. It's an interesting question, and I think it's also a conundrum in medical education, because you can bring in patients, panelists who talk primarily within the medical model, and if that happens within the medical education, then all students see is actually someone who operates within the medical education, within the medical model. So it's actually also, I'm going to answer your question in a second, but just putting this in a medical education context, I think it's important to bring in people who can actually represent the social model and be disability advocates, versus just patients who may think, oh, I cannot do this because of my disability, or my body prevents me from doing things. I mean, those are important perspectives, and you will see those patients a lot. But I think it's also important to show the range of perspectives by people with disabilities. And oftentimes disability advocates have great views to share in that perspective. But from your question, oh, thank you. From your question, I mean, there are patients who, it's not uncommon to see people who focus really on their function, and coming from a rehabilitation background, that's often a question that I get asked. What if people really want to get fixed because they want to function better? You have to meet the person where they are, and if that's what they really want to focus, you start there. But you also want to give room for, these are things that you may want to consider. You may encounter some environmental barriers when you actually try to go out and do things. How can we manage those? How can we strategize those together? So you can have those conversations, but it doesn't mean you know, focusing on the social moderator doesn't mean that you should disregard what they think is important for their own improvement or recovery.
Thank you. Other audience questions, please go ahead and put them in the Q&A. If the audience continues to be silent, I'm going to pose a question back to the audience and say, you know, for those of you who are on this call who have interest obviously in health equity and may or may not have clinical education or other educational experiences in this area, what have you experienced about this topic? Have you seen disability included in DEI discussions? Have you seen it excluded? Any thoughts or experiences to share from the audience? So while you think about that, Danbi, I'll ask you one last question here. I know one of the challenges of this study was attempting to get a high response rate for this survey during the midst of an unprecedented global pandemic and public health emergency, which clearly affected the participants here. And you talked a little bit about response bias too. Given all of that, do you think, how generalizable do you think what you found is for the non-responders? In that, do you think actually it's even worse that you probably got a more positive response bias and had people respond who are actually doing something around disability in their medical curriculum?
Yeah, I think we definitely got people who are more interested in were doing things in their medical education versus people who don't, because we actually had only one person who said they're doing nothing. And there were previous surveys that report about 50%, 52%, I think, of medical schools are addressing these disability competencies, but the rest of them are not. So I think I wouldn't generalize. I wouldn't be given, especially given our response rate and everything. I don't think it's particularly generalizable to all medical schools, but it gives us a good picture of, even with, you know, these people who are doing this, there is not enough, and there are very few who actually do longitudinal training over 4 years with multiple opportunities for students to explore this topic. So yeah, there's definitely more work to be done.
Still lots of room for improvement.
Yes.
This has been very, very helpful in getting a general sense of sort of the current state among medical schools and how they're dealing with disability. I'm going to give one more opportunity for any last questions, thoughts, or experiences that the audience would like to share. I'll just pause for a moment.
I'm also happy to share while we are waiting. Oh, I don't know if there's something in the chat, but I didn't get to talk about future directions of the study in the discussion, given the short time for the presentation, but I feel like there needs to be better understanding of the ableist culture within overall in the medical world. I think that includes medical education and practices in a medical setting. I have been part of another study where we are interviewing healthcare providers working with COVID-19 patients with disabilities, and we're hearing a lot of, you know, ableist attitudes towards patients with disabilities. And part of it is the training, but there's also an overall culture, I think, that needs to be shifted, and better understanding of those, I think, would be interesting, and also cultivate the better environment for physicians with disabilities to be part of the workforce, because I think that's also part of the culture that is preventing a lot of the more diverse health workforce in this area. So just wanted to add that, but thank you.
Thank you so much for sharing those future directions. going to go ahead and pass it back to David to close the session today.
Well, thank you, Tracy, and thank you, Danbi. It was a wonderful presentation, and Tracy, you did a great job moderating, if I may say so. And personally speaking, I found it very interesting. I've never really thought about this issue through the health equity lens before, and so it was a good learning opportunity for me, and I hope those in the audience also appreciate, which I'm sure they did. It was very interesting. But with that said, I guess we'll go ahead and end the event today. So once more, thank you for the presentation, and thank you for those of you in the audience for attending. I hope everyone has a good afternoon. Take care. Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.